and share screen, lest I forget that. Okay. So you should be able to see my screen. If that's not true, let me know. So welcome to Hypermobility 102 about postural orthostatic tachycardia syndrome, or POTS, and mast cell activation syndrome, MCAS, and as they're associated with hypermobility spectrum disorder. And I definitely am not going to be able to share everything, even everything I know, which is a small amount compared to what is known about these conditions, but hopefully give you enough information to see how it fits together with hypermobility and why it may be important to manage these as well. Okay, and I am Leslie Russek, and I'm an associate or full professor emeritus of physical therapy at Clarkson University in the US. My usual disclaimer that I can't provide individual medical advice in this presentation. The information I give is generally applicable to hypermobility, but everybody's personal situation can be different, and to take that into account as you interpret this information, and always to discuss options with your healthcare provider before starting a new management approach. This is the second of 9 lectures that I have. We did basics of hypermobility last week. Next week, hopefully we'll do pain management, then safe exercise selection, and then we'll see if there's enough interest to continue on with gut issues, fatigue, headaches, and breathing dysfunctions. There are recordings for all of these on my webpage and the slides as well for past presentations if you're interested. I will have these little green speech bubbles periodically referring to one of these lectures where there might be more information. So for example, related to the gut, there's a lot more information in my Hypermobility 106 lecture. So my objectives for today, hopefully that you can recognize the signs and symptoms of POTS as the most common form of dysautonomia and to understand what that means, to describe some self-management strategies for POTS, because there's a lot that we can do for ourselves, to identify the medical approaches to POTS management, things that you might talk to your medical care provider, and to recognize signs and symptoms of mast cell activation syndrome and some basic self-management approaches for MCAS. So why are we discussing POTS and MCAS in a series on hypermobility? Well, POTS, MCAS, and hypermobility frequently coexist as what we call the terrible trifecta. These 3 conditions exist together. They seem to be physiologically linked. We don't entirely understand how, but we have some hypotheses. If you put them together, they look a lot like fibromyalgia, and probably half of the people who are diagnosed with fibro probably have hypermobility, POTS, and MCAS, perhaps instead of fibro, perhaps in addition to fibro. Also of current interest, if you combine POTS, MCAS, and chronic fatigue syndrome / myalgic encephalitis, that looks an awful lot like COVID long haul. And this may be a mixed blessing for those of us with hypermobility and POTS and MCAS as a result of our hypermobility or linked to our hypermobility, because there's a lot more interest in the medical profession because we're seeing so much of this in the COVID long haul patients. For those who are interested in the link between, or the similarity between the terrible trifecta and fibro, I have an article that's pretty easy reading on the internet that explains how we can mistake patients with either hypermobility, POTS, or MCAS for people with fibro. And I see it all the time. I get a lot of patients referred to me diagnosed with fibromyalgia when they really have the terrible trifecta. So we'll start with dysautonomia and POTS and why it's so common in hypermobility. But first, talk a little bit about the different types of dysautonomia. So dysautonomia refers to a dysfunctional autonomic nervous system, and I'll explain what the autonomic nervous system does in just a moment. And dysautonomia is the umbrella term. It's the overall term for all of the conditions that are associated with dysfunction of the autonomic nervous system. POTS is one of those, and it happens to be the most common form of dysautonomia and happens to be very common in hypermobility. Orthostatic intolerance is also quite common and can be very common in hypermobility as well. And we'll talk about how orthostatic intolerance and POTS are similar, and you may sometimes present with one and sometimes present with the other. And it basically comes down to whether your heart rate's able to compensate with an increased heart rate. So POTS occurs in part because blood pools in the lower extremities, so the blood vessels are too stretchy, just like everything else is too stretchy. You go to stand up and those stretchy blood vessels allow the blood to pool in your feet. And if the blood's in your feet, it's not getting to your brain. Your brain really needs a lot of blood, a lot of oxygen. And so there are really two possibilities. Either your heart beats really fast to try to get more blood to your brain, in which case you have POTS. If your body is not able to compensate with an increased heart rate, either just because that's who you are, or maybe because you're taking medicine, such as anxiety medicine, that prevents your heart rate from racing, then you're going to present with orthostatic hypotension, which basically means you're not going to have enough blood pressure to get blood to your brain, and you're going to feel really lightheaded and dizzy and possibly pass out. And both of these are common, and people can have one or the other depending on how their body is responding. So how common is POTS? Well, we really don't know because it's not diagnosed very often, or it's not diagnosed as often as it should be. Many people require at least 4 years and 7 physicians before they're diagnosed with POTS. So the prevalence is probably a lot higher than what we think it is. In the US, we think somewhere between 500,000 and 3 million. And this is more people than everybody with multiple sclerosis and Parkinson's put together. And so it's unfortunate that POTS isn't recognized because it really is quite a lot of people. We think maybe 1% of all teenagers may have POTS, especially young women. And about half of the people with POTS had an onset before they were 18 years old. It may not have been diagnosed, but they started presenting with symptoms. So it's really quite a lot of people. And of course, the prevalence is much, much higher in hypermobility because we're especially vulnerable to it. So I've been talking about the autonomic nervous system. And for those of you who aren't familiar with the anatomy, we have 2 parts to the autonomic nervous system. One is called the sympathetic nervous system, and that's your fight or flight system. That's the system that gets you all revved up so you can either fight that saber-toothed tiger or run really fast to escape the saber-toothed tiger. So it shuts down everything that's non-essential for fighting or fleeing. So it'll shut down your gut and your reproductive organs, but it will activate your lungs and your eyes so that you can see, so you can breathe. It'll send blood to your muscles so that you can fight. The other part of the autonomic nervous system is called the parasympathetic system, and that's called your rest and digest system. So the parasympathetic system is active when we're resting, and it's key to digesting properly. When the parasympathetic system is activated, it decreases our heart rate. So the sympathetic system increases the heart rate, parasympathetic system decreases the heart rate and encourages digestion and allows for sexual activity. And these 2 systems are inversely related, that when one goes up, the other goes down. And so if you have a dysautonomia, typically you have an imbalance between these 2 systems. The vagus nerve is particularly important part of the parasympathetic system. It goes from your brain all the way down to your gut, It's called the vagus nerve because it's the vagabond. It's the traveler. It's the longest cranial nerve in the body. It goes from your brain all the way down to your sexual organs. And 20% of the vagus nerve sends instructions to these organs. So it facilitates digestion. It helps to adjust for blood sugar. But 80% of the vagus nerve is information going up to your brain, telling your brain things like, are you hungry? Are you full? Do you need more energy? And when the vagus nerve is disrupted, information in both directions is disrupted. So the vagus nerve, if there's a problem there, it can actually change the information that gets to your brain. And we know that the vagus nerve is not functioning properly in people who have POTS. And so you'll often see people talk about vagus nerve exercises, ways to activate your vagus nerve that helps to calm down your autonomic nervous system, facilitate digestion, decrease your heart rate. Dysautonomia can affect the whole body because there are autonomic nerves that go everywhere. And so you may have brain symptoms. Fatigue is a key symptom, brain fog, headaches, lightheadedness. It can affect your mouth, dry mouth, trouble swallowing, your eyes, your skin. It has a significant effect on your heart. It can make your heart go too fast, tachycardia, or too slow, bradycardia. It can make you feel like you skip a beat. It can cause chest pain. It affects your blood vessels, immune cells, bladder. Big effect on the stomach and intestines and gallbladder. So it has a big effect on the organs and control of the organs. And many people will have involvement of all of these systems, perhaps more in one place than another. Just a sec. Okay. What does POTS look like? Well, if a person with POTS gets we call it a POTSy event in one foot, they may have this purple blotchy skin. It's called acrocyanosis, so cyanosis for turning purpley blue. And you may have it in both feet, both hands, one foot, as is shown here. I've had patients who I ask them, it's like, does your skin turn purple and blotchy or pale? And they're like, oh, no, 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 no. And then I look at their feet and it's like, yeah, it looks like this. This is not normal. And it means that the blood vessels too much blood is pooling in the skin there. Classic example of how a POTSy person responds. So a healthy person takes a shower and feels really bright and refreshed. A person who with dysautonomia after a shower feels exhausted. It's like they took a 5-minute shower and they're already exhausted. They're foggy. They can't concentrate. Their skin turns blotchy. Their heart is racing. They're feeling faint. Their legs are swelling and their blood is pooling. And this is because hot water or a hot environment is actually a POTS trigger. It brings blood to the skin. And if the blood is in your skin, it's not getting to your brain. And if it's not getting to your brain sends out a panic attack. So what are some of the causes of POTS? Well, it seems to be associated with other conditions, hypermobility, irritable bowel syndrome. We don't know which causes which, but it's certainly those conditions are correlated. It may happen with viral infections, possibly certain vaccinations, trauma, surgery, pregnancy are common ones. Anything that lays you out, you're bedridden for a week or two, because when you're bedridden, your autonomic nervous system has nothing to do. And so it takes a break, then you try to stand up and your autonomic nervous system doesn't remember what it's supposed to do. Intensive psychosocial stress can trigger it. Mast cell activation, that may explain some of the link between MCAS and POTS. Severe deconditioning or bed rest. I've seen some flares of POTS that happened when COVID made us all stay home. People stopped doing their normal exercise routines. And when they weren't exercising, their POTS kicked in. Puberty is another trigger. It's one of the reasons why teenagers are so likely to have it, and women more than men. And we don't know why in many cases. This picture shows how people get into a vicious cycle, and POTS is not something that you have forever. You're vulnerable to POTS, and you may be having a flare of POTS at a certain episode in your life. And this chart kind of explains why. You have a susceptible person, somebody who may be genetically susceptible. So with hypermobility, They may be highly active. And then there's some kind of inciting event. So there may be an infection, surgery, head trauma, severe pain, and forced bed rest. And you combine these two and people develop some symptoms. And they start by developing orthostatic intolerance. They have trouble standing up. They feel lightheaded and dizzy. They can't exercise very well. They're just too tired. And so then they decrease their activity because you don't feel well. And so what do? Well, we rest. But unfortunately, that leads the autonomic nervous system to become even more deconditioned. And it adjusts, your body adjusts your blood volume and your heart activity such that your symptoms get worse. You have even more symptoms when you stand up. You're even less able to exercise. You go back to bed or you exercise less, and then you get into this downward spiral. And you may alternatively have too much sympathetic activation, which is POTS, where your heart races really fast, you have GI problems and headaches, your body's trying to compensate, but it's still not a good solution. And so people get into this downward spiral, and we can help people reverse this downward spiral. And I've been able to work with some people with POTS who are bedridden and get them back to having a healthy, active lifestyle. But it can sometimes take a year or so. So some characteristics of people with POTS. So there's a big study that was done in England. 92% were female, 81% were in the childbearing years. The most common symptoms were fatigue, dizziness, and near fainting. We call that syncope or pre-syncope. Palpitations, so heart palpitations. In some people, this was interpreted or diagnosed as anxiety. Fainting or blackouts, brain fog, or trouble concentrating. About a third of the people had to stop working due to POTS. So we're not talking about feeling a little tired or a little bit anxious. These are really severe symptoms that can sometimes stop people from working. And of school-age respondents, 50% missed 3 months or more of school. So it can have a huge functional problem. There are some specific POTS-related headaches, and I talk about that more in Hypermobility 108. About somewhere between 40 and 95% of people with POTS have headaches or migraines, with migraines being most commonly diagnosed. Migraines are also a dysfunction of the autonomic nervous system, so it kind of makes sense. Sleep disturbance can also, the sleep disturbance that POTS causes can trigger headaches. And then there's a special kind of a headache called a coat hanger headache, I'll explain. And POTS is commonly overlooked in patients with migraine. And there's some articles about migraines that say anybody who has a migraine ought to be assessed for POTS. And so there may be some more recognition of POTS that way. The diagnostic criteria, and there are instructions at this website, and I just added this today, so this is not in the slides that were printed out. And you can actually do a POTS test at home if you have a pulse oximeter and a blood pressure gauge. The gold standard is a tilt table test, and that's shown down here on the bottom right, where they strap you to a table. You start out horizontal for at least 5 to 10 minutes. That's important. Not everybody does the test correctly, but you should be horizontal for 5 to 10 minutes. And then they tilt the table up to 60 or 70 degrees, and they monitor your heart rate and your blood pressure. If your heart rate goes up more than 30 beats per minute compared to your pre-tilt value, then that would be a positive test, and measurements should be taken for a total of 10 minutes. And research shows if you stop the test before 10 minutes, then you may miss people who are positive. And for those who are doing the stand test, which is what I do in the clinic, I don't have a tilt table. You have a person lie down for 5 to 10 minutes, and then you have them stand and lean back against the wall so that they don't use any muscles to stand there, or they don't use very many muscles. They need to stand completely still and not talk. And you'll measure their heart rate and blood pressure again over 10 minutes. So usually at 1 minute, 3 minutes, 5 minutes, and 10 minutes. For children, the heart rate has to increase at least 40 beats per minute because their heart rate's normally more variable. People will report increased symptoms when they stand and feeling better when they lie down. So they'll stand up and they'll feel lightheaded, dizzy. They may feel anxious. Their heart may be racing. They may feel flushed. And the symptoms should have lasted for more than 6 months. So it's not just something that you're dehydrated today, but it's something that's ongoing, and an absence of another cause of orthostatic symptoms. So obviously, if you just lost a lot of blood, or you're seriously dehydrated, or you're taking certain medicines, there are other things that can cause an abnormal POTS test. So this is how POTS is diagnosed, and it's actually a very straightforward, pretty easy diagnosis to do. Like I say, with a little bit of equipment, you can do the test on your own. Research now shows that it's even better if you have them lie down again for a few minutes after the test and you take their resting heart rate again. And that's what they'll explain there. So what are some common POTS triggers? That is, if you have POTS, what makes it flare up on any given day? Heat is a big one. So hot weather will do it. Hot showers. Remember the example I told you before of somebody who took a shower and came out feeling awful. Eating, especially if that's refined carbohydrates and sugars. Carbohydrates and sugars, or a large meal, pulls a lot of blood to your digestive tract. If that blood's in your digestive tract, it can't get to your brain. If it can't get to your brain's going to complain. Rapid position changes, so sitting supine to sitting, or sitting to standing quickly, being dehydrated, the time of day. For women, their menstrual cycle, deconditioning, prolonged bed rest, illness, pregnancy. So this is often a trigger or a flare for people. Alcohol will aggravate it, and inappropriate or unaccustomed exercise. And POTS UK has a lot of really excellent information on POTS. So before I go into some management approaches, I'm going to open up for questions, and feel free to unmute yourself to ask a question, or you can post them in the chat if you like.
Hi, Leslie. My name's Chrissy. Just one question. I don't consider I have POTS, but what about sensory perceptions through the brain, like emotional things? Does it create feelings of, I don't know, not depression or anxiety, but feeling emotional or out of, what would you call it? Out of body experience type thing, surreal feelings. It's more feelings than anything. Does it?
It can. It certainly can. So it definitely causes anxiety, and it often is misdiagnosed as anxiety or panic syndrome. And I often find people are being medicated for anxiety or panic when they actually have POTS. But when people feel lightheaded, they can feel kind of drifty. They may feel cotton-brained. It can make people emotional. It's not the primary presentation, but when you feel drained and foggy, it can be really stressful and upsetting. And so it certainly can trigger an emotional response, and it can certainly make people feel like they're kind of floating away from the world.
Yeah.
And there are some other questions in the chat, so I'm going to go through some of those. So Wendy asked how stress impacts POTS and MCAS, and I'll talk about MCAS later, but stress makes everything worse. But stress definitely makes POTS worse because stress activates the autonomic nervous system, your fight or flight system, and that tends to make the heart race even faster, which tends to evoke more symptoms. And so stress definitely makes POTS worse. And one of the management approaches for POTS is to do stress management, deep breathing, slow breathing, to help calm the sympathetic nervous system, activate the parasympathetic nervous system. And we'll see when we get to MCAS that stress triggers MCAS as well. Sarah asks, is a tilt table really needed? And cardiology declined a tilt table test referral, saying treatment is the same for orthostatic hypotension. And I actually believe that a tilt table is not needed. I think a stand test is a good idea to at least confirm whether somebody has either POTS or orthostatic intolerance, but the management is much the same. Most of the management, self-care is very safe to do. And so it's not risky to drink more fluids or add electrolytes to your system or wear compression stockings. So I actually don't recommend a tilt table test in the US where we pay for things like this. I can do a stand test in the clinic in 15 minutes. A tilt table test costs about $3,000 of medical care, and you don't really learn anything more. And the thing about a tilt table test, well, it's true for a stand test as well. If you've already started managing your POTS, so if you think you've got POTS and you're drinking lots of fluids and getting a lot of electrolytes and you're wearing compression stockings, then your POTS test might be negative because you're not presenting with the symptoms anymore. You still have POTS, it's just managed POTS, and that gets messy. You really, to have a good test, you should stop taking any medicines that affect your autonomic nervous system. You should stop water loading and electrolyte loading. Stop doing all the things that I tell patients to do for a day before the tests, because otherwise you won't have a positive test because you're taking care of it. And that's the thing about POTS. When you manage it, if you manage it, the test will be negative. You'll feel fine. You will no longer have POTS. You're still vulnerable to it, but you won't be presenting with the symptoms. So Taryn asked, can the symptoms of POTS come and go week to week? Absolutely, because it depends on how well you're managing it, both with your conscious efforts of water, electrolytes, how hot it is outside, how stressful things are, how well you're sleeping. And so if you've had a bad week, you may be POTSy this week. If you've had a good week, you may not feel POTSy. And so the symptoms definitely come to go, not just week to week, but you can have a flare that lasts for 3 months and then be good for 2 years and then have a flare that lasts for 6 months. You're vulnerable to POTS, but whether you have the symptoms any week may vary. Sarah asked, can POTS symptoms be triggered by movement like raising the arms, tilting the head to look up and down? Good question. So raising the arms actually should decrease POTS symptoms because the blood will come out of your arms into your reservoir, your heart and your reservoir. Although for some people, raising their arms is enough of an exercise that it may be stressful. Typically, POTS isn't triggered by just raising the arms. Standing up, yes, but raising the arms is not one of the things that typically aggravates it. Moving the head up and down, I'm going to answer yes and no, but it's probably because moving the head up and down is affecting the cervical spine. People who are hypermobile sometimes have an unstable cervical spine, and that may trigger symptoms. So that can make you dizzy, that can make you pass out. So it's not actually triggering the POTS. So if your symptoms get worse when you move your head, you probably have something going on in your neck. The POTS itself isn't being changed by the neck motion. I'm going to get to the coat. Am I going to get to coat hanger headaches? I'm going to get to coat hanger headaches in the session on headaches. If we have time at the end, I can't say everything in each of these sessions, so hold on that. Or if you're particularly interested in coat hangers, go watch the video on the headache session. And I apologize, I just can't answer every question and finish on time. Sarah asks, is there any way to determine whether symptoms like cognitive issues and brain fog are from POTS compared to other issues like cervical instability or intracranial pressure? That's a great question as well. And the other thing to add in there is attention deficit disorder and autism spectrum disorder, which are both more common in people who are hypermobile. And so people with ADHD present with similar cognitive issues as people with POTS, and they can look very similar. There are some similar medications as well. So one of the ways that we try to tease out if the symptoms are due to POTS versus other issues is whether neck motion or neck position changes the symptoms. So I actually had a patient today I was looking at, and when I tipped her head forward, she got sleepy. That's not POTS, that's a neck issue. So if neck motions if neck motions change your symptoms, then there's something going on in the neck. The intracranial pressure is a little bit harder because to change that, you have somebody lie down or get up, and I think the symptoms are going to reverse. So if you have high intracranial pressure, when you lie down, you feel worse, but with POTS, when you lie down, you feel better. One thing to know is that while many of the symptoms of POTS subside within a few minutes of lying down and propping your feet up, the cognitive issues and brain fog actually does not subside as quickly. And so you can't just ask a person, well, lie down and see if you can think more clearly. The cognitive changes don't respond quite so quickly. Can POTS cause vomiting on a regular basis? I don't think the vomiting would be due to the POTS. So vomiting is common in people who are hypermobile, but it's probably not due to the POTS. It's probably due to issues in the digestive tract. And if you're interested, you can watch my Hypermobility 106 on the GI tract. And I talk about a couple of the hypermobility issues that lead to vomiting. I will talk about dumping syndrome, which is a POTS-y thing. But I don't think the vomiting is typically due to POTS, but it is common in hypermobility. And if you have both of them, it's related to the whole terrible triad. When I talk about diet changes for POTS, I'll talk a little bit, but mostly about electrolytes. I can't get into all of nutrition today, so I will talk a little bit about electrolytes and diet issues, but not comprehensively. Zinnia says, I see a lot of symptoms that can be confused in the diagnosis if the patient also has neurodiversity, such as autism. So yes, autism spectrum disorder, attention deficit disorder, those neurosensitivity conditions are more common in hypermobility. There are some theories for why that I won't go into, but hypermobility is definitely associated with those neurosensitive conditions. And since POTS and hypermobility go together, you're going to see a lot more of it with the POTS. We don't know whether it's due to the POTS or the hypermobility. I don't know if research has been done looking specifically at whether people who have POTS but not hypermobility are more likely to have autism. There's some really interesting science coming out now on the neurophysiology behind that. Another person failed tilt table test, blood pressure went up to 200, stayed the same, heart rate changed. Yeah, failing the tilt table test. So it does sometimes happen. It's very frustrating. It may be if you didn't go off of all of your normal management approaches, then you won't necessarily see the normal changes that would be positive for the tilt table test. But there are also other forms of dysautonomia. If your blood pressure goes up, then there's obviously some other issues going on with your cardiovascular system. Okay, so I'm going to go back to the lecture. Do feel free to put questions into the chat anytime. And when I get to my next question slide, I will read through them. So there are some physical counter maneuvers or countermeasures that you can do if you're feeling particularly POTSy. So I was with a young lady today, the one that I was playing with her neck position, and she sat up and she's like, whoa, I feel really woozy. And so we actually did some of these things, squeezing a rubber ball or even just pumping your hands. That will help to get blood out of your arms into your cardiovascular system, crossing your legs or tensing your leg muscles, pumping your muscles. If you're standing, swaying, shifting, tiptoeing, walking, marching in place. This may be why some people naturally fidget a lot, that they're naturally trying to get their blood back up to the brain. If you feel really faint, squatting, sitting, lying down, squatting and leaning forward, putting your head between your knees are all good solutions temporarily. Just make sure you're very careful about standing back up. Some things like forceful coughing. So when you cough, you create pressure in your thoracic space, and that helps to force blood out of the chest and into your circulatory system and up to your brain. Negative pressure breathing, so breathing through an impedance device, so kind of like breathing into a balloon or sucking through a straw. Skin surface cooling, this can be a handy and easy one, spraying cold water, particularly cold water on your face. But for people who have that awful experience of taking a hot shower and feeling like they just crawled out of the grave, cooling the water down so that the water is as cool as you can tolerate at the end of the shower, or just spritzing yourself with water can be helpful. So these are some things, quick things that you can do to help cope with an episode of feeling really lightheaded or flushed or having your heart race. So some of the overall management approaches depend on exactly what physiologically is going on with you. And so there are a couple of things that may happen. So your heart may be getting weak. You may not have enough blood to pool in your feet and get to your brain at the same time. And so for your heart, we want to get you exercising. And that can be difficult because you may be really tired and fatigued and you may not tolerate exercise. I'll talk about how to gradually progress into that. Hypovolemia, not having enough blood volume. There are a bunch of things that we can do about that. So increasing both fluid and salts. It turns out that pure water doesn't always get absorbed effectively. And so water with some electrolytes, you can use table salt. There are also the electrolyte additives that you can add to water can be helpful. You can also encourage your body to retain more water by tipping your bed so that the head of the bed is 6 inches higher than the foot of the bed. So you put blocks or bricks underneath the bed. What happens is with your head being a little bit higher than your feet, the sensors in your neck that tell you whether you have enough blood in your body say, ooh, we don't have enough blood volume, so we need to hold on to water. And that can be helpful. Compression garments can be very helpful. And there's a lot of choices now with the athletic compression garments. So athletes also like compression because they don't want too much blood pooling in their legs either. And I'll talk about what pressure compression is helpful in a little bit, but this can help to decrease blood pooling in your legs. It can make a big difference if you're having a lot of POTS symptoms and you've never tried compression. Try it because my patients often say they feel a big difference. And then the countermeasures I showed you before, things that you can do to help manage symptoms on a short-term basis. So reassuring patients so that they understand what's going on, increasing both fluid and salt intake. Some people can do it with just salty snacks. Some people like the electrolyte liquids. These are a few choices. Do be careful if you have chemical sensitivities. Some of these have artificial sweeteners. Some of them have sugar in them. So just be careful if you have sensitivities to those. Managing your fatigue. So there are a couple of options here. Pacing yourself, not trying to do everything all at once. A graded exercise program where you start low, go slow. Lying down with your feet elevated. And I think it's kind of interesting. There's a yoga position where you lie down and you prop your feet up on the wall. And that's exactly what you can do to manage fatigue, because once you get enough blood getting to your brain says, oh, I'm not so bad off as I thought. If you're taking medications that slow your heart rate, reconsider. So it's kind of a catch-22 where beta blockers such as propranolol slow the heart rate. And a lot of doctors who are not very knowledgeable about POTS say, oh, your heart's beating too fast, I'm going to give you a beta blocker to slow your heart rate down. And it's like, great, now your heart's not beating too fast, but you're also not getting blood to your brain. And your brain then says, I'm really tired. And so I've had a number of patients who were put on beta blockers to treat the POTS. And yes, they stopped having tachycardia, but then they just were too tired to do anything. And so be careful with beta blockers. Sleep hygiene is important. And I go into that a lot more in the session on sleep, raising the head of your bed, and then managing anxiety. And for a lot of people, when they realize that there's a difference between psychological anxiety and physiological anxiety, and sometimes they realize it's like, oh, my body's anxious. It's not my brain that's anxious. My body's anxious. And you realize that's a POTS attack. I can do things. I can lie down and prop my feet up, and that can help to manage the anxiety. So a little more on managing fatigue. And I can't go into everything on this slide, but just realize that there are a lot of options to use. So avoiding aggravating factors, so avoiding dehydration, extreme heat, prolonged rest, standing for too long, making sure you pace yourself and you prioritize. Strategies to help make sure you're getting enough fluid to your brain. So fluid intake, exercise to improve your conditioning, compression stockings, possibly also abdominal binders. And then there are the strategies that we can use to improve the venous return blood getting back to our head. There are, of course, some medications, and I'll show you some of them. As a physio, I don't prescribe, but it's helpful to at least know there are different categories of them. And then there are some psychosocial things that we can do as well to help people cope with fatigue. Managing sleep is really important. So pain may interfere with sleep. If you're hypermobile, you may have pain all the time. You may have pain that's worse when you're sleeping, because it's like, oh, that my shoulder hurts, my hip hurts, I can't get comfortable. So general pain management, positioning yourself, using pillows as you need to support your body, relaxation and mindfulness at nighttime can be helpful. There are some principles of sleep hygiene, a cool, dark room, calming down, avoiding computer screens before bedtime, physiological quieting, so some type of relaxation, mindfulness, breathing. Regular exercise, not right before bed, but during the daytime. And there's some good information at sleep.org. And I go into that a lot more in my 107 lecture. Things that you can do to control the blood flow changes. So you've seen some of these already. Be slow in position changes. You may want to contract muscles before you move. So if you're going to stand up and you know you tend to get dizzy, twitch your muscles, contract your butt muscles, and paddle your feet to help pump the blood back up before you move, so that now you have a little bit more blood in the circulatory system, not pooling in your feet. The squatting with your feet tucked or the child pose in yoga are both helpful for squeezing blood out of the abdominal cavity. The coughing that I mentioned before, avoiding heat, large meals, and alcohol, and the skin cooling. So I've mentioned compression clothing a couple of times. What's recommended for people with POTS is somewhere between 20 to 40 millimeters of mercury. So this is generally considered moderate to firm compression. There's a lot of good looking compression garments now. So for socks, if you don't have much of a problem, the knee-high socks can be sufficient. If you have more symptoms, we recommend something that goes all the way up to the waist so that you can get all the lymphatic vessels going up to the waist. These pictures here are of athletic clothing that's compression clothing, and it kind of looks cool. It doesn't look medical, and so you can walk around wearing this and not feel like a medical example. Abdominal binders, so elastic around the belly, can be helpful as well. And POTS.uk has some more information about POTS related clothing. If you have hand problems, so I have patients who their hands hurt, they're not very strong, it can be difficult to pull compression clothing on. You may choose to get 2 sets of clothing that, let's say, are at 15 millimeters of mercury and put one on top of the other. It'll be easier to get on and off. So exercising, if you're really deconditioned, start easy. You may need to start with just lying down exercises that help encourage blood return to your heart, or you may choose to start with this type of exercise before you do more vigorous exercise. So lying down, squeezing a pillow between your legs, squeezing a pillow between your hands, lying down with your ankles in the air, doing alphabets with your feet, leg lifts, basic core exercises, so abdominal exercises that you can do lying down, some gentle stretching, muscle stretching, being careful to protect your hypermobile joints. If you are well enough to do cardiovascular exercises horizontally, you can start those. Pool exercises are excellent. The water provides compression, which helps to improve blood return back to the heart. The recumbent bike can be helpful. Rowing, kind of challenging, but it is more horizontal. I've had patients who said, well, I try to do the elliptical and I do 3 minutes and I crash. And I get them on the recumbent bike and they can do 15 minutes and they're fine. So changing your body position can make a big difference. And then some strength testing, training, and Dysautonomia International has some good examples of that. So some progressions, which may depend on your starting point. I have people with POTS who are on track teams and they run 6 miles. I have people with POTS who are in bed and can barely get out of bed. So starting horizontally, progressing to vertical exercises, start with lower extremity, then add upper extremity. You may need to start wearing compression garments, and you may be able to wean off of them, although many people continue to use them because they just feel better wearing the compression garments. Start with lower extremity resistance or gentle strengthening exercises before you do aerobics. And there are some guides available. So there's something called the Levine protocol. That's like a 6-month protocol. And that's how long it may take to get back into shape. There's no miracle cure for POTS. You have a lot of body reconditioning to do, and it takes months. There are some POTS specific exercise videos at Dysautonomia International. Just be aware that those people don't necessarily have hypermobility, so make sure you're careful about what you do. Gastrointestinal issues in POTS, and I do talk about this a lot more in my 106 lecture. So nausea and vomiting can definitely occur. GERD and indigestion, abdominal pain and bloating, early satiety or feeling full, rapid or delayed gastric emptying, constipation and diarrhea. So all of those symptoms can be due to POTS, and eating can increase your POTS symptoms. So it can go both ways. POTS causes GI symptoms, but then eating can make POTS worse. Dumping syndrome is one of the more common GI problems with POTS. There's early dumping syndrome, which occurs within the first, usually 30 minutes after eating, and late dumping, which is 2 to 3 hours later. And basically what happens is the food just goes right through, you dump it out. But as that's happening, your autonomic nervous system's getting traumatized. And so you will feel weak and flushed and dizziness. The diaphoresis means you're going to feel sweaty and flush. You may have racing heart rate, cramping. On the bright side, it's self-limiting. Once you dump everything, then it's gone. And some of the things that you can do about this is avoid drinking fluids with meals. Make sure you're not drinking anything 30 minutes before to 30 minutes after, and avoiding high carbohydrate meals. Medications, I'm not going to say too much about it. I as I said before, as a physio, I don't prescribe medicines, but I do try to educate my patients about what the options are. And I like this slide, comes from an article from 2018, because it talks about how the different symptoms in POTS may benefit from different medications. So what most doctors who are not familiar with POTS say, it's like, oh, your heart is racing, I'm going to give you a beta blocker to slow your heart rate down. If that's your only symptom, that may work for you. But if your problem is that you're passing out, or you have brain fog, or you have constipation, then different medications may be more helpful for you. And making sure that your doctor understands which symptoms are giving you problems. So I have one patient who's got a lot of blood pooling. So her feet swell terribly, her hands swell terribly. And her doctor gave her fludrocortisone, which increases blood volume. And that just made her swell worse. And he should have thought it through better. But realizing that different medicines can help with different symptoms. They come in different categories. So there are the vasoconstrictors that squeeze the blood vessels to try to prevent it from pooling. Midodrine is the most popular of those. There are those that help you retain more fluid, which you don't want to do if you have lots of swelling. Fludrocortisone is the most popular of those. There are those that slow your heart rate. The beta blockers and propranolol are the most popular of those. And then there's some antidepressants that can be helpful as well. You want to avoid medications that are vasodilators or that will increase your heart rate. These aren't prescribed for POTS, but you may have them prescribed for another condition. Okay, so I'm going to pause again for questions. Okay, so Deidre said that she found raising the head of her bed by putting a pillow under the mattress also helps with GERD and easier abdominal breathing. So, yep, that can help. You just want to make sure your whole body is tilted. Having a couple of pillows under your head won't help, but what you've done by propping up your mattress should work well. And yes, it definitely, tilting your bed is one of the recommendations for GERD as well. Are there other questions? Feel free to put them in the chat or unmute yourself. Okay, I'm going to keep going then, because I still haven't gotten to mast cell activation, which we're going to talk about next. So first, what's a mast cell? So mast cells are part of the immune system, and they're important. They have an important job protecting us from invaders from the outside. And you are familiar with mast cells, whether you've named them or not, because they release histamine during allergic reactions. So if you have allergies, or if you've had a cold, or you've had bug bites, you're familiar with antihistamines, that if you can inhibit the histamine, it calms down the symptoms. Well, mast cells are the main culprit that release histamine. And so if they are overactive and they release too much histamine, you have mast cell activation. They are important cells. They do have a job, but they need to stay within their job description and not be overactive. There are mast cells everywhere in the body. And so mast cell activation can affect every system. But there are three systems that are primarily responsible for protecting us from the outside world. One is, of course, your skin. And so skin symptoms are very common: flushing of the face and neck, hives, rashes, itching, awful itching with or without a rash, all tends to be quite common. Your respiratory tract, because you're breathing air in and out. People often have allergies or asthma or shortness of breath. So these may actually be signs of mast cell activation. And then your gut, because the gut is actually the outside of your body, and your gut wall protects you from the food that you eat. And so gut symptoms, particularly diarrhea, nausea, vomiting, abdominal pain, bloating, and GERD. And so The question that was asked before with vomiting can happen with POTS. It's probably more likely to happen with mast cell activation. Other systems can also be affected, the brain in particular. There are a lot of mast cells and glial cells in the brain, and when they're overactive, they make the nerves overactive. So people will have headaches, brain fog, trouble thinking, anxiety, and depression. And then the other systems as well. Prevalence, again, we don't really know. There's not an agreed upon diagnostic criterion for mast cell disease. It's been argued for quite a while. But there are some estimates that it may be 17% of the people, and a lot of people are getting misdiagnosed as asthma, allergies, irritable bowel, and migraine, all very common conditions. These are some of the ways the skin may look. So you may have these sort of non-specific rashes. You may have these blotches, just purpling. This is called dermatographia that you can write on your skin. So you scratch the skin lightly and it welts up. But also if you tend to really swell up when you get bug bites, that might be a sign of overactive mast cells as well. These are one of the sets of diagnostic criteria. So typical symptoms of severe, recurrent, episodic symptoms. So if you look at that chart that I showed you of the different symptoms that you may have, it has to involve at least 2 organ systems. They like to have a biochemical marker, but the lab test for this is highly flawed and it tends to come out negative. You get false negatives a lot. And so there is not a good lab test at this time. And then basically people get better with the right kind of medications. And so the way I tell patients is if it looks like mast cell activation and you respond to medications that we use for mast cell activation, then it's probably mast cell activation. Some of the common triggers, so stress definitely triggers the mast cells. So someone before asked about stress. Stress can cause a huge mast cell flare. Medications, and often it's the inactive ingredients. So you go to the, well, I don't know what you guys do. We go to the pharmacy and the pharmacist says, oh, we changed our formulation for the medication, but it's exactly the same medication. It's just the base material is different. And most people don't care about that. But if you have mast cell activation, you can have a huge flare just because it's a different base material that the active ingredient is in. Certain medications can also trigger the mast cells to be more reactive. Foods are a huge issue. So many people, most people with mast cell activation have food triggers, especially histamine containing or releasing foods. And I'll give you some examples. Alcohol, especially red wine and beer. Odors, people tend to be very sensitive to smells and chemicals. So a smell can give them a migraine, or exposure to a cleaning chemical, insect bites, hot and cold temperatures, exercise. So you can have any or all of these as triggers. And this comes from TMS for a Cure. It's an excellent resource with information. Migraines and mast cell activation, the triggers are almost exactly the same. So migraines are reported in 63% of people with mast cell activation. We know that mast cells contribute to neuroinflammation, so swelling of the nerves in the brain, and that histamine in the central nervous system causes migraines. And I wouldn't be surprised if they find out that migraines and mast cell activation are really 2 sides of the same thing. I've listed here the different triggers, and you can see it's the same things most of the way down. So management, avoiding the triggers, and that's what you have the most control over, figuring out what you're sensitive to, especially foods. It's probably histamine containing or releasing foods, but it could be any sort of food. Substituting safe meds for mast cell activators, so changing either the type of medication or even the formulation of the medication. Physiological quieting, so things like relaxation, meditation, yoga, helps to calm your immune system, and that will help to calm the mast cells down again. It's not a miracle cure, but if each of these can help you 5 or 10%, and you do 5 of these things and you're 50% better, that's a good deal. And then there are a bunch of medications. Histamine intolerance. So histamine intolerance and mast cell activation aren't exactly the same, but there is a lot of overlap because mast cells release histamine. If your body doesn't tolerate histamine, you can see in these pictures the different symptoms that you may have, a lot of the same symptoms that people have with mast cell activation, POTS, and hypermobility. And what happens when you have histamine intolerance is histamine crosses from your gut into your bloodstream. So then not only do you have gut issues, but all the other systems in your body are at risk. And some foods either contain histamine or release histamine. There's an enzyme in the gut called diamine oxidase that normally breaks down histamine. And some people lack that enzyme. And there are some foods and medications that inhibit the enzyme. There is actually a blood test for it, and that you can take DAO supplements. At least here in the US, we can buy them over the counter. And it's an interesting experiment to do to see if taking DAO supplements helps to calm down some of your, especially GI symptoms. So a low histamine diet, some of the foods that are good are shown on the left, and some of the foods that are bad are shown on the right. So in general, fermented foods, cured foods, alcohols, and then some specific vegetables, fruits and vegetables tend to be irritating. One of the tricky things about histamine, though, is that as foods get more ripe, they tend to have more histamine. And so a banana may be okay today, but that same banana is not okay tomorrow because it's too ripe. Or a food may be okay for you today, but the leftovers aren't okay for you tomorrow. So it's pretty complicated. Some people benefit from the low FODMAP diet. And I go into this more in the session on the GI tract. There's a lot of information available on this. So some people with mast cell activation find the FODMAP diet decreases their symptoms. Best information's from Monash University. So mast cell medications, this is really a very new area. So there are what we call H1 antihistamines and H2 antihistamines. And in general, the H1 antihistamines help with itching, abdominal pain, headaches, and brain fog, where the H2 antihistamines help more with GI symptoms. There's also some medications that are called mast cell stabilizers, although all of these medications help to calm the mast cells down. And some medications called leukotriene inhibitors. And then aspirin can be helpful, but can also be harmful. So don't do that unless you're doing it with a knowledgeable provider. And this information comes from TMS for a Cure, and they have excellent information on this. This is just kind of an FYI. I mentioned at the beginning that the terrible triad and long haul COVID seem to overlap. And this is a table from an article, descriptions of conditions similar to long COVID in terms of their presentation and potentially their management. So the long haul COVID is at the bottom. This is the myalgic encephalitis, chronic fatigue syndrome, POTS, mast cell activation. And so all three of these seem to be ways that our body respond to stress. And hopefully with the unfortunate event that there are more people with long haul COVID, we'll have more knowledge about POTS and mast cell activation as a result. So in summary, POTS and dysautonomia and MCAS are common in people with hypermobility. They're often overlooked by doctors. There's a lot you can do yourself to avoid aggravating factors and to do more to care for yourself. Many of my patients can manage their POTS on their own once they know how to recognize the signs and what to do. Mast cell activation is a little bit trickier. In the US, at least, some of the medications are over the counter and are very safe to use. And so that, in addition to avoiding triggers, can be very helpful. And for both of these, improvements are often slow. So don't get discouraged. Remember what I said, one approach may help you 5% or 10%, but you keep adding those 10% together and you can feel better. Don't expect to find one miracle cure that's going to make you 100% better right away. And even once you're doing all the right things, it takes time. It takes months to get over this, even once you are doing all the right things. My last couple slides have some resources. POTS UK is excellent. Dysautonomia International is excellent. For MCAS, TMS for a Cure, and Mast Cell Activieren, and they do have an English website that are excellent, and some basic resources for EDS, and then citations for my articles. And I will pause again for questions. Okay, so Karen asks, you mentioned asthma, shortness of breath as could be due, or as MCAS. Can a trigger be exercise or something else for shortness of breath? So exercise is one of the potential triggers for mast cell activation. And as long as you distinguish between the normal short of breath, so if I run up the stairs, I'm going to be a little short of breath. If I walk across my bedroom, I should not be gasping for breath. That's abnormal shortness of breath. So exercise definitely can be a trigger for mast cell activation. The heat in the body activates the mast cells and they release their histamine. There are other reasons for shortness of breath. Remember, POTS itself can cause shortness of breath. Being deconditioned if you haven't been exercising can also cause shortness of breath. Kelly says compression clothing can help with physiological calming. Absolutely, and that's a really good point. That compression clothing has been used with children with autism and ADHD for a while, where the compression is very soothing. So I haven't recommended it for that reason, but I will start to do that because that's a great point. Thank you, Kelly. Deidre. Deidre has some medical issues and went on a low histamine diet and found it was a huge difference, and she no longer needs to take asthma medicine and her GERD is greatly reduced. Good for you. A lot of people probably react to histamines and don't know it. And so I'm glad that you found something that works. Those are all the questions in the chat. I know I've gone a little over my hour, but I'm happy to stay and
Sorry,
answer.
Leslie, I tried to put a question in chat, but it obviously didn't work. It's Chrissy here. I get a lot of rashes in the mouth, like red blisters. Is that something that could be associated? It's similar to skin rashes and that, but the doctors haven't been able to diagnose what causes it. It's just, okay, you must have eaten something that's done it or something. Yeah.
Yeah, it can be a mast cell-y thing. So mast cell causes rashes wherever those mast cells get irritated. And absolutely the inside of the mouth gets exposed to all sorts of things. And so it could be something that you're eating, but it could also be something that's more systemic, that it may simply be that your mouth breaks out with the rashes more easily than other parts of your body. But yes, it definitely could be a mast cell-y thing. And I would first look at foods, certainly if you tend to get it after you've been eating, what have you been eating? But if you get it and you're like, okay, I haven't eaten anything in 6 hours, then look at things like stress, temperature, odors, chemicals that you may be exposed to. Other triggers can cause the reaction in your mouth, even if the mouth itself wasn't directly exposed.
I've actually just through this think it might be histamines because I'm an asthmatic and I also take histamines for sinus and that. So just thinking there might be a link. And thank you very much. Appreciated your time.
Yep. Rebecca asked, oral allergies that come and go. Could this be mast cell activation? It certainly could be. You can also have regular allergies. And so the fact that you have mast cell activation doesn't mean you don't have asthma or other allergies, but any type of allergy that tends to fluctuate could be mast cell-y, or mast cells could amplify your allergic response. Can hay fever be part of this? Same answer, that you can have just plain hay fever Mast cell activation can make your hay fever worse. It's the same cells reacting. So hay fever, you could kind of consider it a little microcosm of mast cell activity. Mast cell activation is when your mast cells are overreactive in multiple systems in your body a lot of the time. So yes, hay fever could be part of it, but there are plenty of people who just have hay fever as well. Any other questions? Okay, so next week's session is on pain management. Pain's often a problem for people with hypermobility. And so we'll talk about things that you can do to take care of yourself. If you understand your pain, learning how to manage it, better understanding where it might be coming from can help you to control it. So I hope to see some of you next week. Jennifer, are you still there? So she posted the Maori blessing at the beginning, so we'll at least think back on it again as we close. Okay, thank you all. Be well. See you next week.
Thank you so much, Leslie.